Today, we're going to discuss OB emergencies, some of the most unique, challenging, and rewarding calls you'll encounter as an EMT. For many providers, OB calls can create anxiety because they don't happen every day. Most EMTs will see relatively few deliveries during their careers. However, when these calls occur, they often move very quickly and require you to make critical decisions under pressure. The good news is that most deliveries are uncomplicated. Our job is to recognize normal labor, identify when something isn't progressing normally, and provide safe, effective care for both the mother and the newborn. The objectives and goal of this class is to recognize abnormal presentations during childbirth and manage them effectively in the field. We will also review neonatal resuscitation and cord management in accordance with AHA and NRP guidelines. While childbirth is a natural process, complications can develop quickly and without warning. As EMTs, your ability to remain calm, recognize life-threatening conditions, and provide timely interventions can make a critical difference for both mother and newborn. By the end of this lesson, you'll have the knowledge and confidence to manage these high-acuity, low-frequency emergencies safely and effectively. Let's begin by reviewing the anatomy and physiology of pregnancy and normal labor so we can better recognize when something isn't progressing as expected. Before we can recognize when something is wrong, we need to understand what normal pregnancy and labor look like. As EMTs and paramedics, we aren't expected to be obstetricians, but we do need a solid understanding of the structures involved in pregnancy and the normal process of childbirth. Knowing what's normal allows us to quickly identify abnormal findings and potential emergencies. Let's start with a few key structures. The uterus is the muscular organ where the fetus develops throughout pregnancy. During labor, the uterus contracts to help move the baby through the birth canal. The placenta develops during pregnancy and serves as the lifeline between mother and fetus. It delivers oxygen and nutrients to the baby while removing waste products. Any problem involving the placenta can quickly become a life-threatening emergency for both patients. The umbilical cord connects the fetus to the placenta and contains blood vessels that carry oxygen-rich blood to the fetus and return waste products to the placenta. Later in the lesson, we'll discuss situations where the cord itself becomes the emergency. The cervix is the lower opening of the uterus. Throughout pregnancy, it remains closed, but during labor it dilates and allows passage of the fetus. Finally, the vagina and birth canal provide the pathway through which the baby is delivered. Remember that in OB calls, you actually have two patients, the mother and the fetus. Any condition that affects one often affects the other. Now let's briefly review the stages of labor. The first stage of labor begins with contractions and ends when the cervix is fully dilated to approximately 10 centimeters. This stage can last many hours, especially in first pregnancy. The second stage of labor begins when the cervix is fully dilated and ends with the delivery of the infant. This is the stage where EMTs are most likely to encounter an imminent delivery. And the third stage of labor occurs after the baby is delivered and ends with the delivery of the placenta. Now that we understand the basic anatomy and physiology involved, let's talk about what we're actually going to do when we arrive on scene. One of the most important decisions an EMT makes on an OB call is determining whether the patient needs rapid transport or whether delivery is likely to occur before reaching the hospital. Your assessment helps you answer one critical question: is this delivery imminent? Like every call, we start with scene safety. Remember that childbirth involves significant exposure to blood and body fluids, so appropriate PPE is essential. Gloves are the minimum. Eye protection is strongly recommended. I once cut an umbilical cord and had pressurized blood cover my face, so get those glasses on. As you approach the patient, ask yourself, does she appear uncomfortable? Is she having contractions? Is she actively pushing? Can she answer questions? A patient calmly talking through contractions is very different from a patient who is grunting, bearing down, and unable to speak. Some history questions are: once you've established your initial impression, gather a focused OB history. The first question is, how far along are you? A full-term pregnancy is approximately 37 to 42 weeks. Knowing gestational age helps us anticipate possible complications. Next, you can ask, what is your due date? Patients often know this answer, even if they don't know their exact gestational age. Then you can ask, how many times have you been pregnant and how many babies have you delivered? This is important because women who have delivered before often progress through labor much faster than a first-time mother. If a patient tells you, this is my fourth baby, and they all came fast, you should immediately start thinking that delivery may occur very soon. Next, you can ask, how far apart are your contractions? This means measuring from the beginning of one contraction to the beginning of the next. And then how long do the contractions last? Typically measured from the start of a contraction until it ends. Can the patient talk through contractions, or must she stop talking and focus on breathing? Increasing intensity usually indicates labor progression. Next, you can ask, has your water broken? When did it happen? What color was the fluid? Clear fluid is generally reassuring. Green or brown fluid may indicate meconium staining and possible fetal distress. Ask about bleeding. Small amounts of blood-tinged mucus can be normal. Heavy bleeding is not normal and should immediately raise concern. Now let's discuss findings that suggest delivery is about to happen. The number one sign is crowning. Crowning occurs when the baby's head remains visible at the vaginal opening between contractions. Once crowning occurs, delivery is imminent. If you see crowning, you are not transporting, you are delivering a baby. Many patients describe an overwhelming urge to push or bear down. Some describe it as a feeling like they need to have a bowel movement. As the baby moves down in the birth canal, pressure builds on the pelvic structures and rectum, which causes this sensation. Contractions occurring less than 2 minutes apart strongly suggest advanced labor. If contractions are every 30 seconds to 2 minutes and the patient feels the need to push, you need to prepare for delivery. A bulging perineum indicates the fetal head is descending into the birth canal. The tissues around the vaginal opening begin stretching as delivery approaches. If the patient has a history of rapid labor, take that seriously. The phrase, "I barely made it to the hospital last time," should immediately get your attention. Now you have a decision point, transport or deliver. As EMTs, we're constantly making decisions. At this point, you should ask yourself, can I safely transport this patient before delivery, or is this baby likely to be born before we arrive? A good rule of thumb is that if crowning is present, delivery is imminent. If the patient is actively pushing and contractions are very close together, delivery may occur within minutes. Now that we've learned how to assess a laboring patient and recognize imminent delivery, let's discuss abnormal presentations and what to do about it. This is a list of the abnormal presentations that you could face. We're going to go through each in depth and discuss what they are and how to manage in the pre-hospital setting. Let's start with one of the most challenging field deliveries, a breech presentation. In a breech delivery, the buttocks or both feet of the baby present first instead of the head. This occurs in about 3 to 4% of full-term pregnancies. While most breech deliveries are handled in the hospital under controlled conditions, it's critical that we recognize this early and know how to respond if delivery becomes unavoidable. First, identify that the presentation is breech. You'll see either the baby's buttocks or feet emerging first. This tells you immediately that this is not a typical delivery and time is critical. Some key actions are to stay calm and communicate with the mother because panic increases complications. Notify the receiving facility early. Position the mother for optimal delivery and cord perfusion, generally on her back with buttocks slightly elevated or in a knee-chest position if delivery is not imminent. Field delivery of a breech presentation is a last resort. Your number one goal is rapid, safe transport to a hospital with OB capability. However, if delivery is imminent or unavoidable, you're going to support the buttocks and legs as they deliver. Use gentle hands. Do not pull on the infant. Pulling can cause spinal and cervical injury or trap the head behind the cervix. Allow the body to deliver naturally with contractions. The baby's body will typically rotate spontaneously, bringing the back up and face down. One of the greatest risks in a breech delivery is head entrapment, when the head becomes stuck after the body delivers. If the head hasn't delivered within 3 minutes, that's your cue to intervene. The procedure goes like this. Insert a gloved hand into the vagina. Use your index or middle fingers to form a V shape on either side of the infant's nose. This maneuver creates an airway pocket and prevents the vaginal wall from compressing the baby's face. Gently push the vaginal wall away from the infant's mouth and nose to allow air movement. Maintain this position while en route. Do not remove your hand until hospital personnel take over. Remember, you're not trying to pull the baby out, only to maintain a patent airway. Continue immediate transport, code 3. Maintain warmth and airway for the infant if partially delivered. Monitor for cord compression or prolapse. If the cord is visible, keep it moist with sterile saline gauze, and support the mother. Calm reassurance reduces straining and sudden pushes that can worsen complications. Breech deliveries require minimal intervention and maximum patience. Let nature guide, don't force. Do not attempt to turn or reposition the baby in the field. Make sure to document all your observations, such as the presentation type, the timing, interventions, and maternal status. Some complications to anticipate are cord compression, the head entrapment, birth trauma, which is risk of neck, spine, and limb injury if excessive traction is used, and hypoxia due to prolonged delivery time or cord issues. So these risks are why field delivery should only happen when absolutely unavoidable. Your skill in recognizing, supporting, and transporting quickly can make all the difference. A scenario to think about is that you arrive to find a 32-year-old woman in active labor in housing. On inspection, you see the baby's buttocks emerging from the birth canal. She's pushing involuntarily. Evans Hospital is 5 minutes away. What's your plan? So if you're thinking rapid assessment and preparation for possible field delivery, you're going to call for additional resources if needed. You're going to avoid traction and manipulation of the baby. You're going to support the infant's body and let delivery proceed naturally and prepare to manage airway and cord issues. Then you were thinking right. So to summarize, a breech delivery in the field is rare but high risk. Your priorities are to recognize and to support. You're going to think about airway maintenance if needed, and then rapid transport. Never pull the baby, never delay transport, and always anticipate airway and cord complications. A limb presentation occurs when a single arm or leg presents first through the vaginal opening. This type of presentation indicates the baby is not properly aligned for delivery. It's extremely rare, about 1 in 300 to 500 births. It cannot be delivered safely in the field. Your priorities here are recognition, protection, and rapid transport. If you see an extremity emerging first, this is a limb presentation, and that means this patient needs an immediate hospital delivery. Do not attempt to deliver this baby in the field. Limb presentations almost always require surgical intervention. The steps for this emergency are simple, though. Do not touch or manipulate the limb, because touching can cause reflex movements that worsen malposition or trauma. Position the mother in the knee to chest or Trendelenburg position to relieve pressure on the cord and presenting limb. Gravity will help move the baby off the cervix slightly. Administer high flow oxygen to optimize fetal oxygenation. You're going to monitor the cord. If it prolapses, immediately manage as a prolapse cord emergency, which we will discuss soon, and then rapid transport to the nearest OB-capable facility, Code 3. Key points are to make sure you never try to reposition or deliver the baby in the field. Transport the mother in the knee to chest position. Manage complications like cord prolapse per protocol, and let receiving facility know you are coming as soon as possible so they can prepare for surgery. The prolapse cord is one of the most time-sensitive OB emergencies. The umbilical cord slips into the vagina ahead of the fetus, cutting off oxygen as the baby's head compresses it. You may see or feel the umbilical cord protruding from the vaginal opening. The cord may appear blue, purple, or pulsating. Mother may report sudden loss of fetal movement. This is a true time-critical emergency. Immediate transport is needed with notification to the receiving facility. You're going to position the mother in the knee to chest position or Trendelenburg position, which is the hips elevated. These positions reduce cord compression. Then you're going to manually relieve pressure by inserting 2 gloved fingers into the vagina. Gently lift the fetal head off the cord. Maintain that position throughout transport. Get comfortable, because this is where you stay until someone at the hospital takes over. Keep the cord moist using sterile saline-soaked gauze. Do not attempt to push the cord back inside. Administer high-flow O2 and calm the mother. The goal is to maintain perfusion until surgical delivery can occur. Your fingers may need to stay in place all the way to the hospital. Never delay transport for any reason once the cord is identified. In a prolapse cord, the baby's lifeline is literally in your hands. Keep pressure off the cord, keep it moist, and get moving. Now, let's discuss multiple births, twins or higher order multiples. While rare in the pre-hospital setting, it is vital to know how to manage them. The first baby may deliver normally, but the second or third may not. Patient history during your exam is important here. The mother will have a history of multiple gestation or ultrasound confirmed twins. After one baby delivers, strong contractions often resume within 5 to 10 minutes. The second fetus may have a different presentation, such as head down or breech. Prepare for double the needs. 2 complete newborn setups will be needed, so warm towels, BVMs, clamps, and suction devices. Allow the first baby to deliver normally. After the first delivery, clamp and cut the cord. Note the time of birth. Place the first newborn in a warm area. Prepare for the second delivery. Expect a short delay before the second baby's contractions resume. Manage according to the presentation. So if it's a cephalic, then you're going to proceed with a normal delivery. If it's breech, we're going to manage per breech delivery protocol. And do not forcibly rupture any membranes for the second baby. Expect more postpartum bleeding here. The uterine atony risk is higher. So continue uterine massage to promote contractions. This is where you find the fundus and apply massaging pressure to it. This is not comfortable at all to the mother and will most likely hurt, but is extremely important. Monitor both newborns for respiratory effort, tone, and heart rate. Be prepared for neonatal resuscitation for either or both babies. Label and separate infants to avoid confusion. Always anticipate multiple placentas. Each baby usually has its own. Some common complications are prolonged or delayed second birth, prematurity and low birth weights, and postpartum hemorrhage. In multiple births, organization and communication are key. Manage each baby as a separate patient and stay ready for the next delivery. Shoulder dystocia happens when the baby's head delivers, but the shoulders get stuck behind the mother's pubic bone. You'll notice the turtle sign, which is the head retracts slightly after emerging. To manage this emergency, just stay calm. This is an urgent but manageable situation. Instruct the mother to stop pushing temporarily. Perform the McRoberts maneuver, which is you lower the mother's head flat, flex her thighs firmly against her abdomen. This straightens the sacrum and opens the pelvic outlet. And then you're going to apply firm suprapubic pressure, not fundal pressure, just above the pubic bone to dislodge the anterior shoulder. Never pull on the baby's head or neck. If unsuccessful, continue transport immediately while maintaining that position. The McRoberts maneuver is a suprapubic pressure and can often free the shoulder within seconds. Fundal pressure is contraindicated. It worsens the impaction. Use pubic pressure if needed. Shoulder dystocia is about angles and patience, not force. Adjust the mother's position, use controlled maneuvers, and act quickly. If positioning fails, then rapid transport. A nuchal cord occurs when the umbilical cord is looped around the baby's neck. It's common, roughly 1 in 3 births, and often doesn't cause any harm. You recognize this as the head delivers. You see the cord wrapped around the neck. This looks bad, but it's totally manageable. For management, you're going to attempt to slip the cord over the baby's head gently. If it's too tight, clamp the cord in 2 places about 2 inches apart and cut between the clamps. Continue the delivery immediately after cutting. Once delivered, dry, warm, and stimulate the baby per normal neonatal care protocols. Handle the cord gently. Rough manipulation can tear vessels. Cutting is a last resort, only if the cord cannot be slipped over the head. A nuchal cord is common and usually benign. Stay calm, act methodically, and ensure prompt newborn assessment after delivery. Now, let's shift into neonatal care after birth, one of the most time-critical responsibilities we face in EMS. The vast majority of newborns transition well after birth, but about 10% require some assistance and roughly 1% require full resuscitation. Because neonatal physiology is so different from adults, we follow the NRP sequence, which prioritizes ventilation above all else. Immediately after every delivery, whether pre-hospital or in the hospital, we begin with a rapid 3-question assessment. Ask these questions the moment the baby is delivered. Number 1, is the baby full term? Preterm babies have higher risk of respiratory distress, hypothermia, and poor tone. This helps you anticipate the need for active warming and respiratory support. Number 2, is there good muscle tone? A vigorous term newborn should flex arms and legs. Limp or floppy tone is a major red flag for hypoxia or prematurity. Number 3, is the baby breathing or crying? Effective breathing is the single best indicator of a smooth transition. If they're gasping, this is not adequate. No breathing or poor respirations require immediate intervention. If the answer is yes to all 3 questions, the baby usually only needs routine care, which is drying, warming, and staying with the mother skin to skin. If the answer is no to any question, we begin the neonatal resuscitation sequence. The steps in the first 30 seconds correct most newborn issues. Focus on thermoregulation and airway positioning. Actions you take will be to dry the baby thoroughly, which removes amniotic fluid and stimulates breathing. Warm the baby. Neonates lose heat 4 times faster than adults. Hypothermia worsens respiratory distress. Then you're going to stimulate the baby. Rubbing the back or flicking the soles is enough. No aggressive stimulation. Next, position the airway. Neutral sniffing position. Avoid overextension. Then you're going to clear secretions only if obstructive. Routine deep suctioning is no longer recommended. Suction only if there is visible obstruction or positive pressure ventilation is ineffective because of secretions. The next 30 to 60 seconds, evaluate heart rate and breathing. Heart rate is the most important indicator of neonatal perfusion. If heart rate is less than 100 beats per minute or the baby is apneic and gasping, start positive pressure ventilations. Ventilation is the key to almost all neonatal resuscitation success. If the baby is breathing but cyanotic, you're going to reposition the airway, suction if secretions are obstructive, support oxygenation with blow-by oxygen. Pulse oximeters may take a moment to register, so rely on heart rate via auscultation initially. After 1 minute of effective ventilations, which is considered the ventilation checkpoint, reassess heart rate and determine the next steps. If heart rate is greater than 100 beats per minute, the baby is improving, so continue routine care, support breathing as needed. If heart rate is less than 100 beats per minute, this indicates inadequate ventilation. You're going to reassess chest movement and correct any problems such as mask seal, head position, airway obstruction. Make sure you're ventilating at a proper rate, 40-60 breaths per minute, and you have adequate pressure for chest rise. If heart rate is less than 60 beats per minute, despite 30 seconds of effective positive pressure ventilation, initiate chest compressions, coordinated with ventilation. Use a 3-to-1 ratio, which is 90 compressions, 30 breaths per minute, to total 120 of those a minute. Use 100% O2 and monitor with the EKG if available. These steps are rare in the field, but part of the neonatal resuscitation escalation. So consider intubation for better ventilation control, establish IO access, administer epinephrine if heart rate remains less than 60 beats per minute after 30 seconds of effective positive pressure ventilation, and 60 seconds of coordinated ventilation and compressions. Evaluate for any reversible causes such as hypovolemia, which you would consider a bolus, or pneumothorax, especially in difficult deliveries, trauma, or poor compliance. Review the neonatal resuscitation protocol algorithm after this class and discuss the timing of this algorithm. It's very important to get that down to memory. Remember, magnesium sulfate is used for eclampsia, not preeclampsia. We do not have to witness the seizure, though. If a seizure occurred prior to our arrival and it was witnessed by someone, then this patient should get magnesium. Monitor for toxicity because it can cause cardiac arrest. If a patient arrests while receiving mag, stop the infusion immediately. The way we give it is 5 grams and 50 mLs over 5 to 10 minutes. IV push only in cardiac arrest. For meconium-stained fluid delivery, you just need to assess the baby. If the baby is vigorous, with good respiratory effort and muscle tone, then they can stay with the mother and use gentle cleaning of the meconium from the baby's mouth and nose with a bulb syringe. Suctioning with a suction machine is not needed. In the presence of a fetal distress with poor muscle tone and respiratory compromise, you will immediately initiate resuscitation efforts as stated before. The AHA recommends delayed cord clamping for about 30 seconds. The benefits are that it reduces hemorrhage, reduces transfusion need, and NEC, which is necrotizing enterocolitis risk. There are some potential drawbacks such as higher bilirubin levels. 30 seconds is enough time for us to get ready and then cut the cord. In summary, identify abnormal presentations early. Prioritize rapid transport when delivery isn't safe, and follow neonatal resuscitation guidelines precisely. Your calm, organized response can save 2 lives at once. Now we will do the discussion questions as a class. After these, go ahead and review the neonatal resuscitation protocol. So, what is your first action in a prolapse cord? When do you clamp and cut a nuchal cord? What's the heart rate cutoff for starting compressions in a newborn? Discuss these and review the protocol together. Have fun.